I want to say thank you again for joining us. Dr. Stuart Saunders is here today to speak to this group about foot and ankle arthritic disorders. I don't hear much feedback right now, so I won't mute anyone, but if you do have a question, feel free to type it in the chat and we'll have an open discussion after the presentation, or raise your hand and we'll give you the ability to ask your question at the end of the session. So again, thank you. Here is Dr. Stuart Saunders with foot and ankle arthritic disorders.
Thank you for everyone who's logged on today. We're going to start off talking about ankle arthritis. Just so you guys are aware, ankle arthritis occurs in about 70% of our patients that we see. Most commonly, it's after ankle fractures. It can also be associated with inflammatory arthritis or other associated conditions. And usually, it can be pretty significant when we see it on x-rays as seen here to the right of this screen. What we commonly see with people with arthritis, they have pain, limited motion. It can also affect their function and ability to move. They have startup pain or stiffness when they first get up. You can also have some swelling and warmth in and around that joint depending on the level of the arthritis. And ultimately, the goal with arthritis is to reduce pain and improve your function. So some treatment options that are available that don't involve surgery, and one of those involves a steroid or cortisone injection. You may have also heard of Synvisc or PRP, anti-inflammatories, as well as custom ankle braces. Over here on the right-hand side, this is on the top, you see an example of someone getting a steroid injection. On the bottom is a top-of-the-line brace that people can also get for their ankle arthritis. In terms of operative treatment, which we'll touch on today for the ankle, there's things such as open or arthroscopic debridement, ankle arthrodesis or fusion, as well as total ankle replacement. So first, briefly touching on conservative treatment. So what cortisone does is it kind of breaks the pain cycle. This can help reduce any kind of the effects of the flare-up from the ankle itself and can provide weeks to months of relief. You can get these every 3 to 4 months. And even if you have steroid injections in other joints, that does not preclude you from being able to get an injection in your ankle joint. There are newer studies, newer things, flexogenics, things of that nature called Synvisc or PRP. Unfortunately, it is not approved by the FDA for the ankle at this point in time. NSAIDs have historically been very good for helping to reduce your pain and symptoms. And then bracing and PT, what these are doing is trying to help you maintain an appropriate range of motion to give you the best functional ability to be able to avoid surgery if at all possible. So what about platelet-rich plasma? That's something that's kind of gotten more news and in the literature over the past 3 to 5 years. The problem with it is that there's variability over what's the correct formula to use. So while this has shown great promise, it still is variable in terms of how much potential relief it may give you, even though there is some literature out there that does support that doing a PRP injection before proceeding with any additional surgery to see if that helps reduce some of the symptoms that you're experiencing. Now moving on to surgery. What's seen here is just an example of an arthroscopic surgery procedure where we go in and we clean out the joint using small incisions. We do know that depending at the time of surgery, the amount of arthritis that we see, that the less amount of arthritis at the time of surgery, you have a better result, whereas the higher amount of arthritis that we see at the time of surgery, your results are not going to be end up being as well for you. And unfortunately, sometimes we do get fooled by x-rays, whereby the joint looks better than it actually is when we get up there and are able to see it at the time of surgery. Just to touch on this briefly, so in case if you've had any prior injuries, this is kind of the precursor to ankle arthritis. It's called an osteochondral lesion of the talus. And you can see here on the x-ray right here, that's where we're starting to see the degeneration, the breakdown within the joint itself. Usually these can be treated at first with conservative measures. You can get steroid injections if you happen to have one of these on your x-ray, but more than likely this is just a precursor to let us know that arthritis is already setting up within the ankle joint. So then moving on to the next surgical type, so we have something called an ankle fusion, or basically where we fuse the bones of the joint together. This has been the gold standard for end-stage arthritis for several years because it provides excellent pain relief and has a low complication rate. Even after the surgery, your foot still is able to move up and down, but it's not without risk, okay? Even with this, you're giving up something to gain pain relief. And so the biggest side effect of this is that we know that you would start to develop arthritis in the adjacent joints of the foot and ankle as early as 8 years after a fusion, and we know that by 20 years after this fusion, you'll start to see it in one of the adjacent joints, 100% guaranteed. That doesn't mean that it's going to be symptomatic, but we do know that it does occur. And so here we can see just examples on this of x-rays of pre and post-op of a patient who's had an ankle fusion. Unfortunately, the video is not working at the bottom. That still shows the ability to have the 20 to 30 degrees of motion even after the ankle fusion. Here's just another example of an end-stage patient with ankle arthritis, bone on bone, flattening, joint space narrowing, who went on to get an ankle fusion, doing quite well with plates and screws as seen here. So why don't we fuse everyone? So not everyone's happy with having a fused joint. Okay, the function's good, but it is not normal. Most commonly we see that you're, walk with a slower or a slower as well as a little bit less length, or so you don't have a long stride anymore when you're walking. And like we said earlier, you can still potentially develop arthritis in the other joints in and around the ankle. In addition, some common complications with the fusion is that there is, depending on comorbidities such as smoking or diabetes, or if you decide you want to walk on it too soon, the fusion sometimes doesn't heal, and that's where we can get anywhere from 8 to 10% rate of that fusion not healing. But overall, it's been a very good surgery with very reproducible results for pain relief. Here we can see is just an example of a patient who has a great fusion, but we're starting to see arthritic changes as demonstrated by these arrows in other areas of the foot and ankle. And that's just due to excessive stress on the surrounding joints. So now we're getting into kind of a newer, in terms of, and by newer I mean it's only been around, these newer models for about 10 to 15 years for total ankle replacement. So this is very similar to a knee replacement in terms of we're replacing both sides of the joint with metal, and then we're also using a polyethylene liner or a heavy plastic between either side of the joint. In terms of, we only have survival data in terms of, we know that at 5 years survivorship is over 85%. From 8 to 12 years, we know that survivorship of a total ankle is 75%. So it's not as good as total ankles or hips, which have been around a lot longer, but we are making strides to catch up in the total ankle market. So pros to the ankle replacement: it not only alleviates pain, but it allows you to keep your range of motion that you already have. The downside to it is that you can have some same issues as with a knee replacement. You can have loosening in and around the ankle replacement. You may also develop some instability whereby you may need some additional soft tissue procedures. And so the reason why ankle replacement unfortunately isn't as successful as the hip or knee is because the forces across the ankle are 2 to 3 times higher than the hip and knee with each step. So basically it's a smaller joint and you're putting increased force across it. That's why historically the joints have not lasted as long. However, like I've said, these newer models that we have demonstrated here, but with Wright Medical, they continue to show great strides of longer survivorship. In addition to a total ankle replacement, you may also need additional procedures at the time of surgery to further give you the best potential outcome. So ankle replacement is risky, but not absolutely contraindicated if you have severe deformities, if you have some blood supply issues, diabetes, also if there's any potential bone loss. Because what we do is we get additional imaging studies that helps us to better evaluate if you would be a potential candidate for this surgery. So complications or most common complications after total ankle replacement. So you can have delayed wound healing. There is a risk of infection, loosening of your components, or even fracturing around your components. So this is just an example of what a ankle replacement looks like on a model. As you can see, it's metal and plastic in between. And then here's a video of what the normal function of the ankle joint looks like after you've had this implant placed. And so now the newer models for this replacement have grown to where now we can get patient-specific cutting guides. And this is specifically what I do and use for patients because we use a CT scan that helps us to make sure that the implants are appropriately sized and cut for your ankle, just like they're doing now for hips and knees. And so here are these specific cutting blocks. And with these, you can also do 2 different ankle replacements as a result of these patient-specific cutting blocks taken by just using a CT scan. What this does, it allows less time in the OR, which reduces your risk of radiation exposure, reduces your risk of potential complications with not only the surgery itself, but also with anesthesia. And so here's just one patient, weight-bearing x-rays. You can see end-stage bone-on-bone arthritis. And here are their post-op films with their ankle replacement. This is the other ankle replacement called an in-bone. This is for surgeries for ankles that have more severe deformity within the ankle joint. As you can see in this slide as compared to the last one, if you're looking at it critically, you can see in this slide the tilting at the ankle joint, right in this area right here. And so as a result, we use this other construct, ankle replacement, that helps to provide it, once again, so that way when it's all done, you can see that the ankle is right on top and not tilted anymore. And so what we know from this literature that we see is that total ankle replacement not only improves quality of life and return to recreational activity, such as things like biking, swimming, gardening, dancing, hiking, even some patients do downhill skiing, but no guarantees, unfortunately, you're going to get back to full high impact sports if you so desire. But overall, very good results. Moving on down the foot and ankle, we're going to move to the middle of the foot. And in terms of the middle of the foot, this involves the joint in front of the ankle from this area right here. I don't know if you can see my arrow, but it involves 3 joints. Most commonly, it's due to arthritis, just wear and tear. Can also be due to inflammatory arthritis, sometimes if you've had prior trauma or injuries. Most commonly, what we see is pain across the top of your foot. You may also have some bone spurs, or you may have problems with tight shoes, or if you're tightening your laces over the top of your foot, you may feel pain. With time, as this progresses, you may see some collapse of your arch in kind of end-stage severe cases. Just like with ankle arthritis, we start off with non-operative treatment, such as stiff-soled shoes or rocker bottom shoes, such as Skechers brands. Seen here is skip lacing, so this is where you see the laces cross and then they skip the area of the midfoot, so that way you're not putting any extra pressure across that top of the foot. Once again, you can take anti-inflammatories. You can also get steroid injections, and these can be very good for treating and provide you with prolonged relief of your symptoms. Surgical treatment, unfortunately, there's only 2 options for this. One is to remove the bone spurs. As you can see in the top image here, there's kind of a point or a peak. That's a sign of the arthritis. That unfortunately does not address the underlying problem of the arthritis. So even though you have those removed, they can come back or recur. So just be very aware of that. So if you do go in to have those bone spurs removed, just be aware of that recurrence. The other option, unfortunately, is to do a fusion surgery, and that's where we just get the bones of the joints to grow together. We wouldn't affect in terms of don't usually fuse all the joints, but we want to fuse enough joints to help maintain the arch of your foot. Once again, we get a CT scan of the foot to evaluate the joints, the appropriate areas to fuse at the time of surgery, but it takes a commitment. It is a 2 to 3 month commitment of not putting any weight on your foot, and it's a long recovery, but once you've recovered, it's very excellent for pain relief, and you have almost a completely normal foot at the end of this surgery. Once again, just with an ankle, there are associated complications with slow healing or not healing, as well as adjacent joint arthritis or arthritis in other joints. It does not appear to occur as rapidly after ankle fusions just because these are lower stress joints, which means that you don't put as much pressure through these joints, the same amount that you put through your ankle joint. And then moving on now to arthritis of your big toe, also known as hallux rigidus. So this is just a clinical example of this. You may see this, you may know someone who has this, but here's the big toe and you see a big bump across the top. And so this is characterized by limited motion and painful motion, as well as a painful bump, problems with shoe wear. Here's a concomitant x-ray where we see normal joint space here in the lesser toes, second, third, fourth, fifth, and we can see that that joint is basically bone on bone and destroyed in the big toe, and it's got little devil ears or devil horns here, which are bone spurs. And so this is an end-stage kind of arthritic big toe joint. And so what we see normally is if once you get a block to about 40% of your big toe from being able to go up or upwards, that's when you start to develop symptoms with walking, standing, shoe wear. And this, once again, we see it commonly is with these bone spurs. Here's just another example, 2 different extremes. So this is a patient who has pretty severe bone spurring across the top with an additional bone and basically has, only a few degrees of motion before it has this big block of the bone. Here's one at lesser degree. You can see a little bit less bone spur, but a little bit of narrowing of the joint right here. And so once again, based on based on this, you can also once again start off with non-operative treatment, and then in terms of operative treatments as well, we'll kind of go over those. So normally recommend starting off with non-operative treatment, so orthotic, shoe wear. If it's not improving after about a month and a half, you can continue with that. Consider a steroid injection. We normally recommend surgery after you've failed conservative treatment for 3 months. And then surgical options kind of depend on the grade of or how bad your arthritis is in the big toe joint. And so we'll start off with some of the lesser invasive surgeries and then go to some of the other surgical options for worse arthritis within the big toe. And so this is one of those things where unfortunately, you have a bump, but it's something where we need to see x-rays to be able to discuss, because as we see here in these 4 examples, we see 4 different levels of arthritis within patients with very similar symptoms. So here, right here, we see a patient that has kind of minimal cartilage changes. So in terms of these, once again, these are 4 of the same patients with similar symptoms. However, when we get in there at the time of surgery, we can see this patient here has relatively normal cartilage with some mild thinning. This patient here we see has normal cartilage down below in the joint, and then has, about the top portion, about 40 to 45% of the joint is worn down. This patient we see here has normal cartilage on the outside portion, or sorry, the inside portion or inside half of the joint, and worn away here. And then we see this patient actually has 2 loose bodies within the joint itself, and all coming in with the same kind of symptoms. All right, so surgery, the easiest surgery and the quickest recovery is something where we just remove the bone spurs. So this is the top of the joint where we saw those painful bone spurs, and we just remove that and remove this right here. And what this does is it helps to keep your motion and remove those spurs, okay? Sometimes as well, we add an additional osteotomy called a Moberg osteotomy, which I'll show here in a second. And overall, this has a 90% success rate. Okay. We also know that even in advanced stages of arthritis, the literature supports still performing this procedure if there is still any joint space seen on X-ray, because there's up to 85% satisfaction and less than 5% progressed to needing a fusion after this surgery. And so here is an example of the chylectomy. So what this is, we remove the bone spurs. We also make a little cut in your big toe, and we fix it with hardware. And what this does is it allows the good cartilage to start to move along the good cartilage. And so what that does, it helps to also increase your range of motion after surgery. So here's an example of a patient you can see has some changes with arthritis, but still has good joint space, so elected to undergo a chylectomy in this Moberg procedure. Here you can see the side view where the bone spurs have been removed and had that wedge of the bone, or that extra cut in the bone made. And there you can see, this was after just removing the bone spurs, and you can see the increase in range of motion after doing that extra osteotomy. And so that osteotomy helps to get you back more motion to allow you to function, as best as possible to improve outcomes after the surgery itself. Alternatively, there is also just going ahead and fusing the big toe joint. All right, up to 89–90% are very happy with this procedure in terms of they have almost normal shoe wear. Women can even wear up to a 2-inch heel if they want to. If you have big toe arthritis and you just want one surgery and potential to be done after one surgery, then this is the surgery for you to perform depending on your activity level and stage of life that you're in. And so here we can see on the right is a preoperative X-ray of a patient with end-stage arthritis, bone on bone with bone spurring, who elected to proceed with a fusion. So using a plate and screw to hold this bone together to allow it to grow together. And so here's an example of a video of a patient who's had both of her big toe joints fused, and you can see her walking on her toes.
Thank you so much.
And I'll just show that again. It has very good functional level.
Thank you so much.
All right. Now, just to discuss some of the kind of newer surgeries that are out there. So the chylectomy, or the removal of bone spurs, the fusion, those have been around for quite some time. Now there's out there, people have been doing it for about 5 to 10 years, but a partial joint replacement, and this is called a hemicap. All right. The pros to this is that it allows you to weight bear right away after surgery. There's almost 90% survivorship at 5 years, and it's a great option for those who are kind of in between that removal of bone spurs and that fusion. And so it's also a great revision option for patients who may have had a interpositional implant already and that aren't ready for fusion. Okay. The downside to this is that even though it's going in there and going well, we know it's not going to last forever, and that you may need a fusion at a later date and time. As well, this surgery does not address any arthritis that you may have underneath the bottom of the big toe, and so in terms of the ability to return to high impact activities such as running, you may still have some discomfort with that. Just for full disclosure, there is also a total toe replacement that's out on the market. That's where they replace both sides of the joint. So on this side, we're just replacing the metatarsal head where we know that the cartilage gets worn down. Unfortunately, I did not perform a total toe replacement because they have a 50% failure rate and a high complication rate. And so as a result, I did not perform that procedure, but there are providers out there that do perform total toe replacements. In addition to there is something also on the market called an interpositional arthroplasty. It's very similar to the partial joint replacement. What it is it's a silicone implant that sits right in the joint right here. I did perform this for a few years. However, I have gotten away from performing it after my clinical results, as well as other foot and ankle physicians around the country, were not seeing the same clinical results as what was reported with the literature that got an FDA approval in the first place. So in terms of that option, there is something called that interpositional arthroplasty that is still out there. But like I said, I am not performing that procedure anymore. So just in summary, so surgical options for the big toe. So the chelectomy Moberg, so that's the removal of bone spurs plus or minus that extra little cut in the bone. We do that for a majority of patients. The fusion is a great option for patients who have limited motion or an advanced arthritis. The partial replacement is offered for healthy individuals who want to preserve motion, can also be used for revision cases, and also those that are very willing and understanding that this may be a stepping stone before they need a fusion later on. And once again, that interpositional arthroplasty, that's reserved for a very select patient population. And once again, I'm not performing that procedure anymore at this point in time. But I am revising them as needed or as they come to see me. Okay. Last thing I want to talk about, which isn't due to arthritis, but just we also want to talk about bunions and the lesser toes, since we were talking about arthritis as well. And so what is a bunion? So bunion is just that big toe that's drifting over towards that second toe. It's due to multiple issues in terms of you inherited it from mom or dad, due to shoes, can be due to post-traumatic issues. So basically it's multifactorial, caused by multiple things. But it can cause significant problems with shoe wear, balance, and so that's why I wanted to bring it up for today's talk. Most commonly you see pain over the prominent portion of the bunion, worse with shoe wear. Sometimes it can cause nerve irritation, or you can get inflammation of the bursa in and around the bunion itself. It can also cause pain underneath your second and third toes. We see it about 50% of the time can cause a callus or pain specific of that second toe, just because you're walking differently, and to offload that bunion, you're putting more pressure on the other areas of the foot. So conservative care is key. You can use orthotics, night splints, roomy shoe wear, bunion pads. There's all sorts of things that you can do, but once that toe goes towards the second toe, the only way to get it back is with surgery in terms of straightening it. The most common reasons that we perform surgery are not for cosmetic reasons, but to help reduce pain and also to restore function, especially if you're having problems with balance. There are over 100 different ways to treat the bunions. Right now, we are currently trying to get approval to start doing MIS bunions. That's minimally invasive surgery for bunion correction. Unfortunately, I don't have any slides on that at this time, but that is a newer technique that's only been around 2 or 3 years, but seems to be something that is very promising to help reduce recovery as well as decrease the amount of swelling and post-operative complications. So let me just scroll through this real quick. So in terms of surgery for you, when would you decide you wanted surgery? So common questions, so chance of successful outcome, how much downtime will you have, complications, foot surgery is painful, will insurance cover? So to answer these, so very successful outcomes. There is risk. There is, with anything, no risk-free surgery. There is a risk of recurrence of 3 to 7%. How much downtime depends on which foot you're doing. If it's your right foot, you're down for about 6 to 8 weeks. If it's your left foot, you're down for 3 to 5 days, depending on how long you need to be on any pain medicine after surgery itself. Guest foot surgery is painful. but it usually is only for the first 72 hours to 5 days after surgery. The further out from surgery you get, it gets less and less painful. Yes, there are rare cases where you can continue to have pain for weeks to months after surgery, but that is not that common. And from the MIS techniques that they are putting out there, that is also greatly reducing pain. And yes, insurance does cover the surgery. So what we tell patients, again, surgery, if you fail conservative measures for 3 months, primary goal, once again, is to get you in a shoeable foot that gives you good balance and supports. Here's an example of a patient. You can see he has bilateral bunions. These are the x-rays of her left foot. And then those are post-operative x-rays right here where you can see that they are, once again, well aligned. And we're just showing x-rays of the left side. There you can see that the bunion correction that she underwent on the left side as well. But clinically, you can see the better position of the great toe. And then just real briefly about the other toes. So other toes, hammer toes, mallet toes, and claw toes commonly occur in women and greater than men. Commonly see them with, if they develop any painful calluses or problems on the top or bottom of the foot. So treatment recommendations kind of depend on what's bothering you, how much pain, and if you're having any problems with abrasions or shoe wear, because the goal is to get you back into a well-fitted shoe. And you can see examples listed below. So this is a splint that you can wear in your shoe that helps to pull your toe down to allow you to fit in the shoe. These are silicone sleeves that you can wear as well, just to reduce discomfort. And then these are kind of bigger shoes with an extra wide toe box that will further give you support for your toes themselves. If you ultimately decide on surgery, there are other surgical options. Sometimes you can get by with simple soft tissue releases where we just release some of the tendons in and around the toes themselves. Otherwise, you're usually using some sort of hardware whereby it's either screws or wires or other implants, which I'll show you in a second. And so here are examples of screws and wires, just screws. Here's an example of actually a staple. Once again, all of these devices are available that allow you early weight bearing and allow you good function up to 90% satisfaction, as we've seen. As with everything, there unfortunately is nothing that's risk-free. You can have persistent swelling for 3 to 6 months, if not longer. Sometimes you can get a floating toe, which means that toe lifts up. Usually this is not symptomatic or cause any problems with shoe wear. Anytime you do surgery on small areas in and around the toe, you can have potential loss of toe. That's very rare, and usually we see that in people who have underlying vascular issues. Thank you.
Dr. Saunders, I did have a question. You were talking about the bunion and the minimally invasive surgery. What's the difference between the right and left and the recovery of those? Is it just the foot dominance, or you said the right or the left had a little bit less recovery time?
Yeah, so in terms of minimally invasive surgery, and so that's a newer technique. So I'll answer both questions. So minimally invasive surgery for bunions, so that's a newer technique that's come out on the market whereby we're able to use smaller incisions. As a result of that, that allows you to weight bear sooner as well as have less soft tissue issues with swelling, allows you to heal your wounds quicker. It's something that we are trying to get away to courses to try to get more proficient with it because there is a high learning curve with it. But from all the literature that we've seen over the past 2 years, patients are very happy with the minimally invasive surgery if they're an appropriate candidate for it because of regardless of side, reduced pain, reduced swelling, reduced wound complications, and earlier weight bearing. In terms of bunions, right side versus left side, most people are right side dominant. And unfortunately, with the current techniques that we use, the right side, after bunion surgery, you're usually off of it, and we know after foot and ankle surgery that your reaction time to be able to drive a car is greatly reduced for about 6 weeks or so with any foot and ankle surgery. So with the right side, and that being the most dominant side, it's a little bit harder recovery because most people, whether they notice it or not, kind of favor or put more weight, or when they're driving, have that, using that right foot to get around on. Whereas the left side, most people aren't left side dominant. And so that one, like I said, is a little bit easier to recover because it's easier to stay off of it because you're putting more weight on that right side. So that's kind of, where that kind of discrepancy comes between the two.
That makes sense. I'll leave this slide up for a few minutes so that you can write down this information. Again, please feel free to give us a call. We can get you scheduled to see Dr. Saunders so that he can do an evaluation and, discuss your specific needs. Thank you so much for joining us today, and we hope that you have a wonderful afternoon. Thank you.
Thank you.